Good. Alrighty, so we are doing today a demonstration of Wryneck, just a few little tips on how to best approach it with the patient and also how to best treat given how acute and how severely painful the presentation is. Like all of you would have done in your pods today, making sure that we're reassuring. So we have to give the patient the reassurance that they're going to be in good hands, essentially. We have to ensure that the patients understand that unfortunately this is going to be unlike normal adjustments. This is going to be a little bit more painful or uncomfortable than normal given the presentation of the Wryneck. But we also want to make sure that we are confident when we're saying this, so the patient feels very confident when you're coming to work with them. Now, the idea is with the Wryneck, as we know, normally it's going to be a unilateral, so a one-sided presentation. Normally, we might expect to see that there is a head tilt because of the spasm that's taking place. And when you do your range of motion, the patient might only turn very minimally to that one side, but then they might turn very well to the other side. Now, the idea is when we're coming to work with the Wryneck, soft tissue prior is a good way to get started, but also not going too hard on the soft tissue because that might aggravate or that might trigger the inflammatory response, so it might actually make it feel worse. So the idea is essentially, it's called the corkscrew technique. We all would have or should have done this at university. We know that the muscles that are affected with the Wryneck are mainly the SCM, but more importantly, it's the scalenes that sit underneath the SCMs, and we know the scalenes are anterior, medial, and posterior. So they're the ones that are going to feel like a rock, and they are very easily distinguishable. Sorry, bad English. Very easily you can tell the difference between the left and the right side, so you'll be able to tell what the affected side is. Now, the way that I normally approach this, essentially, very gently turn the patient's head, start at the base of the ear, and then the idea is you're doing a corkscrew. So you're going down into the scalene at the same time. You're turning the patient's head into that side. Okay, then come back again, repeat. Sorry, Harrison, just there. So starting from the base, moving the patient's head across, and then you're turning the head. Now you might actually come to, as Harrison has there, you might actually come to that painful area where you can feel that there is the most rigidity or the most spasmodic part of the muscle. You can actually hold that there, whether you hold it for 30 seconds, 60 seconds, within the patient's comfort, but don't be scared to actually hold that as a way to release that trigger point that's in that muscle there. So repeat that a few times at your own discretion, but that's a really good way of just getting that. But again, don't overdo it. The second thing is doing more of an isometric contraction. So the idea is, let's just say the patient is restricted turning to the left. What I'll do, I'll ask the patient to turn to the left as much as they can. Now, hand on the cheek, and now you ask the patient to try to turn to the opposite side. So push your head, Harrison, into my hand. That's it. It's about a 50% contraction. Doesn't have to be too hard, and they won't even be able to do it too hard. So pushing, hold it into my hand, keep pushing, keep pushing, keep pushing. Hold it for about 10-15 seconds, and then release. And then what you'll find, you'll be able to start to turn the neck more with every progression that you're doing it. So again, push into my hand and making sure that you're resisting down. Hold it there, 10-15 seconds, release. And then again, and look, you might be able to do this 3 to 4 times and aim to do it until you can almost get the head laterally again. And the patients would like to see this because they can see, oh, hang on, I wasn't able to get this much, whereas now I can turn it. But again, reinsuring that, yes, I understand it is painful. However, we're interested in getting it to move as much as it can. That way the pain can start to gradually decrease. So again, pushing through here, 10 to 15 seconds, and then back to the middle. Once you've done that, that's when you come and do a manual adjustment. And the idea is confident. You've got to be very confident with this. Advise the patient that they might feel a bit of discomfort, unlike what normal adjustments would be, and patients would appreciate that. And the idea is essentially, get to it, whatever it might be. Try not to put too much lateral flexion on it. Try not to put too much rotation because obviously the spasm that's there. But getting underneath and trying to keep it very short and sharp, and you can do it on both sides. Now, once you're done, get the patient to slowly stand up. Oh, sorry, sit up, please. Face the wall. Okay, and then from here, the patient might feel a little bit heavy because you've just worked on it. So give them a few seconds. And then after that, ask the patient to look to the right. This was the good side, so no problem there. Ask them to turn to the left. And what you normally see is that they are able to turn, not 100% yet, but they are able to turn more than what they did when they came in, and that's all that we are after. So you want to reassure to the patient that my main objective is to get that muscle released as much as possible, introduce as much movement into your neck, and then obviously after that we advise to use heat on the neck, we advise to sleep on their back, we advise no sharp quick movements of the neck, and also if they need to take an anti-inflammatory for the first 2 to 3 days, just as a way to help control or help keep that pain under control, and also making sure that they are seen the next day. And this is the important part of this. Patients would want to be seen. They don't want to be left to fend by themselves. So making sure that they are followed up the next day. That way you can go through their x-rays, show them what their neck looks like, show them the source of the problem, and then, you know, the rest you guys can do for yourself. But there you go, Wry Neck 101. Thank you.